everyone, and welcome to Behind the Mask. This is where we sit down with the people who are shaping the future of surgical and clinical care. So it's not just about the technology, but it's about the teams, the systems, and the partnerships that make everything work behind the scenes. So today's conversation is about something that luckily most people will never see, but it directly determines whether mothers and babies stay safe when pregnancy gets complicated. We're talking about maternal, enhanced, and critical care, and the remarkable story of how one region built the infrastructure to support the 1 in 10 women who become critically unwell during or after pregnancy. I'm joined by two incredible guests. So first we have Dr. Deborah Horner, consultant in anaesthesia and critical care at Bradford Teaching Hospitals. And Deborah is also the chair of the Yorkshire and Humber Maternal, Enhanced and Critical Care Steering Group. That's a long thing to say. Debbie spent the past decade leading the development of MEAC, working to transform how we recognise and care for seriously ill pregnant women. And Viv, who works alongside Debbie as the lead midwife for the MEAC project. So Viv has been in midwifery for 5 decades. A long time, Viv. She started a training in the mid-70s. She's witnessed the whole evolution of maternal care from where it was then to the data-driven systems that we're building today. So I'm very excited for this conversation today. So Debbie and Viv, thank you so much for joining me. So I'm going to come straight to you, Debbie. So can you just give our listeners just a little bit of an explanation on what MEAC actually means and why it emerged about 10 years ago?
So MEAC is maternal, enhanced and critical care, as you've already mentioned. And essentially, it came into being about 10 years ago when a document was being sent round in a draft version that first described enhanced maternal care. And that was a national document that Yorkshire and Humber had sight of early on in its draft format. So what enhanced care is, to start with, so enhanced care starts at the point that you are concerned that a woman may be at risk of deterioration in and around the time of pregnancy and need a little bit of extra care from the staff who are looking after that woman on the delivery suite. And then critical care is the point at which enhanced care transitions into that woman becoming unwell enough to need care, usually within a critical care unit, so an intensive care unit or a high dependency unit. And that normally involves critical care staff, so critical care nurses and intensive care consultants taking on elements of the care of that woman.
Right, thank you. And Viv, just drawing on your experience, obviously being in midwifery for a long time, how do you think that it's changed over those years, and how is it recognised more today?
I think so. So I came in in the 70s, and I had undertaken my nursing training first, and then went straight to midwifery and stayed there for the rest of my career. And it was a very medicalised form of care, was obstetrics at that time. And so we had the doctors that had trained, and they had very good general training before they specialised in their obstetrics. And we had the midwives that had generally undertaken their nursing before they went into that. So that's quite a big difference in the education today. But having said that, I think we worked more in isolation. So there are many units that still aren't part of the big hospital, and they're standalone, but we were very standalone at that stage. And so the obstetricians got very used to actually caring for the women for all aspects of them, their medical care. And it wasn't as shared, it wasn't as multidisciplinary as it is today, and that was the difference. And when it came to kind of emergencies, we'd have things set up like a flying squad. So if a woman had a home birth and she had a retained placenta where the afterbirth doesn't come out, instead of having the midwife skilled up, being able to kind of pop a cannula in if they need to do or anything like we have them today, we used to get a flying squad together, and the flying squad would be kind of the obstetrician, maybe an anaesthetist, that would go out from the hospital. So there were more delays in actually, getting women into hospital, and the isolated work and the different training that was given to all of the midwives at that stage. So that's the biggest difference, I think.
Really interesting. So in terms of the work that MEAC's done, we talk a lot about 1 in 10 women needing that critical care. So Debbie, from your point of view, can you help us understand what that looks like in practice? What conditions are we talking about, really?
Okay, so when we started MEAC about 10 years ago, I'll just give a little bit of the background to how the data and things came about. So when we started MEAC, we got together all of the units in Yorkshire and Humber. So that was 17 maternity units. And we got together the MDT that Viv was talking about. So anaesthetists, obstetricians, midwives from each of those trusts, plus people from managerial roles in the region, to talk about what we needed to do to support each other to better look after sick women. And so that involved some policies and ways in which we work. It involved some training and education for the staff that delivered care to sick women. But it also involved collecting data, because one of the things that became clear to us early on was that this data around those women, particularly the women who became sick and were cared for in maternity, so the enhanced maternal care women, there was no one capturing that data nationally anywhere. And so we didn't actually know how many women were becoming unwell and needing that level of extra care in our delivery suites. So once we started to collect the data in each of the individual units, we were then able to start to understand a bit more about why those women become unwell and how many do. So we've got about 7,000 cases in the database now. And when you look at the average number of cases that each unit is having, roughly speaking, it's about 10% of women, all women who are booked in any unit will become unwell enough to need enhanced maternal care. Only a very small proportion of those will need critical care, so an intensive care unit. Most are looked after in maternity. And the 3 main reasons why those women need enhanced maternal care are blood loss following birth, infection or sepsis following or during or before birth, and then preeclampsia. So that's the condition which involves having high blood pressure in and around the time of around the time of pregnancy.
And when these women sort of come into the unit, I assume, obviously with preeclampsia you would already know, or well, you would likely know, I assume. I'm not an expert.
No, it's all right. Not always. So a lot of the time, what's also been really interesting looking at the data is the majority of the women who require enhanced maternal care have no health problems before they come into before they become pregnant. So it's about 50 to 60% will have no health problems whatsoever. And if they do have health problems, they're often things that are just very well managed in the community. So, for example, asthma or perhaps diabetes, or all of those things which younger women now are having more of because we've got more complexity out in the community. Although some of the women might know that they've got early preeclampsia, not all preeclamptic women will need enhanced maternal care. So often something will happen quite quickly, which will mean that they need enhanced maternal care. And so for the preeclamptic ladies, that would be blood pressure that becomes less well controlled, that needs more drugs to control it, and then the effect that that can have on baby and then the other organs in their body. So it's often happens quite quickly and there's not a lot of warning.
Yeah. Okay, thank you. So before we kind of talk a little bit more about the project itself and what you're trying to achieve, I just wanted to go back to the transformation, because it's really interesting to see how maternity care has transformed from when it first, well, not when it first started, because women have been having babies for a long time, but you know what I mean. So I read a blog that you wrote, Viv. It was really, really inspiring and really interesting, especially now. Obviously, you both know, but our listeners won't know that I am pregnant at the time. At the time, and now, when it comes out, I might not be. So obviously, very interested in this topic and the work that you guys are doing. So when you kind of first started in the 70s and you've seen things like ICUs come out, the introduction of ICUs in the 70s, we've been through the COVID pandemic, which obviously was huge. How do you think some of these kind of changes and advances have impacted the work that you're now doing in MIAC?
Is that for me, Hayley?
Yeah.
Yeah. So I think it's really interesting when you follow it around. So, kind of if we look back at the 70s, we've had the introduction of IVF, in vitro fertilization. We started using CAT scans. We went on to MRIs. We had the global fight of the pandemic, and then we came into kind of routine breast screening for women. All these things that we take for granted, every day. We came through to the 90s, and we brought the MMR in, and the influenza vaccinations into there. And all the time, in the kind of 70s, 80s, there was this, like I mentioned before, the kind of a medicalization, where everybody was pressing for 100% hospital birth. You didn't have many home births in that time, and there was a lot of induction of labours. And then over that time, when we got into the 90s, the women started having much more of a voice, and there was the Changing Childbirth that was produced a document and a plan by the government. So, and it gave it was offering women continuity of carer in their pregnancy and more control over their childbirth experience. So I think that's the biggest thing. And there was a swing back to home births, although there's never been a massive number of them. And with that also came this massive change of we used to be we went to schools of midwifery and schools of nursing, and those were in the local departments that we worked in. And then it swung away and we became more of a graduate profession and trained to degree level in universities. So that brought with it a much more critical mind, I think, to the midwife, and then allowed them to open up, and there would be certain midwives that chose to skill up and be able to offer care more to women who were ill, and you had the rest of the staff that were trained very much in their normal childbirth, and with that training, that basic training, it allowed us to actually identify if there were any issues at all with the women, and then refer to the doctor. And then we had the multidisciplinary way of working, which was a more shared one with the obstetricians, the involvement of anaesthetists coming in at that stage, and all being part of the provision of care. And then we were noticing that we were risk assessing women, in their pregnancy, and who could provide the best care. So in the midst of all that, I think certainly we had to begin to look at care, because there were more women coming through the service, and there were aspects of care. They were still they were risk assessed. They would either come under a sort of obstetrician's care, they'd come under midwifery care then, and then if they came under midwifery care, then we would see these women after their pregnancy, and we would see them up to 28 days, after, not every day, 28 days with their first baby, up to 21 days with that. And then as the pressures have increased over the time, then we have reduced the input postnatally to about 10 days, and the GPs have taken on more of the care and the health visitors afterwards. So those have been the major changes that have taken place in the whole of that time. But also we've become much more of a research-based profession. So we're looking at, and that's the multidisciplinary aspect of it, looking to provide the best care in the most appropriate way to everybody. So there's lots of practices that have changed, you know, and improve the care that the women are receiving.
In that you talk about kind of women's choices changing, and my personal experience, like, I couldn't speak more highly of my midwifery team, and that obviously comes under you because it's Calderdale and Huddersfield, and I have had a few conversations with my midwife about maybe some choices going out of guidance, and they've thoroughly discussed the risks with me. They've been very open and also very supportive as well in terms of uh it's all right, Debbie. Just really supportive in terms of like understanding where I'm coming from and trying to support me through those choices as well. And it, you know, do you see that as a really positive step forward?
Absolutely, it's the way, because you know, kind of from the 90s, it's been looking at, you know, how can we provide you the care and the advice, the best care that you can receive, but you know, you don't always get your choice, because, you know, perhaps with what was happening, you're guided to see that actually it wouldn't be the best of us. Because I mean, I used to say in antenatal classes, because I was a community midwife for many years, you know, what would I want? You know, my birth plan would be, well, I'd like to start maybe a week before the due date or on the due date. I don't want to go over, thank you very much. And I don't really want to have a very painful labour, but I'd like it to be quite quick, and I'd like the baby to come out and breastfeed beautifully, and, you know, also, you know, to sleep quite a bit afterwards, you know, that's what I could wish, and I will get those wishes somewhere down the line, you know, with it. So it's being realistic, and that's, and as long as you are feeling listened to, you have you won't feel empowered to ask that the questions that you can do. You can have that equal participation in your pregnancy and in your care. I'm sure that that's why you're feeling happy with your care, because you've been offered that by the midwife who has looked after you during your pregnancy.
Yeah, definitely. Yeah, and I have to say, going into it, I was quite nervous about conversations, and I don't know why. I just felt it's new to me. But it, yeah, 100%, I've felt listened to and supported the whole time. So it's been good. So I just want to go back to that blog that you wrote, because I noted down that you said that there's a lot of reports they've been constant, always getting reports, and you noted that mortality rates are now at levels that you haven't seen since like 2003 to 2005. What does that tell you when you're putting, or this is for both of you, when you're looking at the outcomes and looking at the plans, what does that tell you in terms of why it's so important right now for us to be doing this?
Debbie?
Either.
If it's for me, just ask again, because I was listening but not intently enough to answer straight away. You can edit it.
No, that's fine. I was just saying that Viv noted in her blog that maternal mortality rates are now at a level that we've not seen since like 2003 to 2005. When you're looking at the work and the impact that you're having with MIAC, how does that impact kind of your thinking and why it's so important right now as well?
Okay, so I think that those of us that were involved in MIAC right at the beginning recognised that maternity care was getting more challenging. So there were more women who were becoming unwell during pregnancy, and the reasons for that we've touched on already, but included women having more complex past medical histories, conditions that perhaps historically would have meant that they wouldn't have been able to have got pregnant, but were, and then were being able to carry a pregnancy through to term. Women choosing to have their babies older as well also impacted on that. And then all of the complexity of a population that was changing in terms of the languages that people spoke, where they originally had come from. So there was a bigger immigrant population asylum seekers, all sorts of different things that were impacting on the complexity of caring for women during their pregnancy and birth. And so I think because we were aware of those things happening, and we'd already started to see those numbers of deaths, unfortunately, nationally, tragically going up, we recognised that we needed to do something to try and firstly recognise when a woman was becoming unwell. So to give the staff who were looking after those women the ability to spot when things were starting to go wrong, to make a quick assessment of the different aspects of what was going wrong, and then to escalate that appropriately to members of the multidisciplinary team, who would then be able to come and start to make plans around how to make things better for that woman and for that baby. And then the next step is actually, once you know you've got a sick woman, what next? So who needs to look after that woman in the maternity unit? Does she need to go to critical care? So in doing that and starting to collect data, that gave us a kind of baseline level of who becomes unwell, what that looks like, and start to be able to identify things that we might be able to change to make things better in the future. So we've already touched on having policies in hospitals to describe how a sick woman should be looked after. The next bit is, okay, so then how do you educate the staff across the whole multidisciplinary team to be able to do the things that you would like them to do to help to make those women better? And then once you recognise why women are getting sick and you know what that looks like, what can you do to specifically change things other than the things we've described already to help prevent women from getting unwell in the first place, or to treat them more quickly and effectively so that you minimize the impact of whatever that illness is. And a good example of things that we've started to do, so we've got our policies, those that started in Yorkshire and Humber are now being adopted nationally. We've got the training, which is training that is available in other places. So we haven't reinvented the wheel with the training, but we have put it in and suggested putting it into all of the units in Yorkshire and Humber. So each individual unit can look at how many of their staff are trained in looking at after recognising sick women. And then we're starting in the new year a project looking at blood loss after giving birth, because we now know that that is the biggest reason for women needing enhanced maternal care in Yorkshire and Humber. And there's various projects that have been done in other areas of the country that have shown that if you do specific, or you look after those women in a specific way, you can reduce the amount of blood that they lose and the outcomes for the mum and also for baby. So all of that information has come from MEAC, and it's a really exciting time now to be starting to look at what can we do with those individual conditions to improve outcomes.
If I can just add to that, then the third aspect of the MEAC project is the data itself. And we have data collection within our maternity services, but it doesn't collect data on women that are requiring enhanced maternal care. So we have no idea of the incidence of this, or anything with that. And we have asked, and the midwives around the units have been fantastic across Yorkshire and Humber, and have collected this data for us. But coming back to, your focus that you were saying on the Embrace reports, what it allows them locally to do is they will have real-time data. So they can have a look at the national reports that are coming through, and they will know their own population. They will know from the data collected how many women of Black and Asian ethnicity have, their areas of deprivation that they live around, the ages of the women, and then they can compare that nationally within their trust, and then look at areas of care that they might like to just focus in on from there. So that's part of us going, as well as the postpartum hemorrhage quality improvement program. They're able to see their data, and they wouldn't have otherwise collected this data in the degree that they are doing now.
What does it take to manage and maintain a database like this? I think you said, did you say 7,000 records?
Yeah.
It's quite a lot.
Yeah, it's been fantastic. I mean, Debbie had the foresight to, when they were setting this up, to say, right, let's have somebody that's going to kind of, roll this out, that's got a research background. So being older, not necessarily wiser. I had the research background. I'm no good with technology at all. So what I was bringing to it was the fact that we weren't going to have research midwives, or nurses, the research team involved in the data collection, which is normally what happens, or the digital midwives in a hospital. We were going to have the staff that were on the floor. And we had to make it as slick as possible, as user-friendly as possible. And working with, net solving and through to Athera has been an absolute joy for that, because I think one of the main things that you've given to us is that, you've been interested in why we are collecting. You have come to conferences, you've heard the stories, the background, and then you've got more kind of, input from, the user kind of perspective with that. So it's really worked well. It's slick. It only asks the questions that we need it to ask. It's all anonymized data. We don't get to see any of the NHS numbers for the women. We have no identifiable information at all on any of the women, because this is an audit. The only thing that we do is actually assign them a case ID number, and that's how they are known to us with it. But we, data integrity, we checked that with the very first version. We've asked all of the trusts that if they thought we were missing a trick, we weren't asking any specific questions which they would like to ask within for their trust. We've said, please tell us, and we've now onto our third data set now. We improve it. We have a look at the Embrace reports that come out, and we keep up to date, and we work with the educational institutions as well, and we have input from there, as well as the multidisciplinary team advising us on what data we should collect. So we think we're collecting very relevant data.
Have you had a lot of feedback kind of nationally on how it's helping them as well?
So I think nationally, the data has helped because that has been a kind of cornerstone of the publications that we have got out there into some very influential journals. And so having the data is really important to show that what you're doing is working. And also that it's required. So that whole 10% figure that I keep mentioning, just that on its own just shows everyone nationally, from a policy perspective, different colleges, everyone who's got a bit of an interest in women who become unwell. It shows them that this is not a small issue. This is a lot of women. And it shines a kind of spotlight on why it's important that we do something about it. So there's lots of other things that people are doing to improve maternity care. But it's really, I think, pushed it up the agenda that this is important, and that collaborative working with critical care. And I think it's really brought the critical care organisations to the party. They were always involved, but I think because they can see what their role is based on that data and based on the publications that we've put out there, I think it has increased the interest, and it's increased the number of people who are involved and interested in pushing this work forward nationally.
And say, I remember speaking to you a couple of years ago, and you mentioned about you. I can't remember the exact figure, but women that came in were, let me get this right. So women that came into the delivery suite or came into maternity care, the people that actually ended up needing enhanced care, you wouldn't have thought would have needed it. So how has that shaped kind of how people are seeing coming in now? Like, what changes have been put in place based on that? Is that right? Have I got that right?
Yeah, you have. So that figure of about 50% of women not having any underlying health problems, I think possibly came as a bit of a surprise to various sort of national groups who were looking at care of women who become unwell in pregnancy. So there was a group, there's a big group of women who have quite complex health needs in and around pregnancy. So say women who've got pre-existing serious health issues, and there is a national, there's been a national push to develop maternal medicine networks, and we've worked very closely with our maternal medicine network in Yorkshire and Humber. And in fact, there's an aligned database to MEAC which captures the information about those women who we know are unwell before they come in. So I think what it's highlighted is that actually having somebody or everyone who has an interaction with a woman in pregnancy, the importance of them recognizing early signs of deterioration and of those women becoming unwell. And that aligns with some other national work that's been going on around maternal early warning scores. But it's on its own, having an early warning score solves part of the issue. But what you need alongside that is an understanding from the staff perspective who are using those scores of why that deterioration might have happened, and an ability to do a very quick systematic assessment of that woman, and then escalate to the right people. So there's a lot of bits of the jigsaw that are fitting together with this, and I feel as though MEAC has kind of put a piece in place that helps staff to understand why women become unwell and supports them to be able to get the rest of the MDT involved and be able to care for those women effectively once we know they're unwell.
How do initiatives like the early warning score and Martha's Rule and things like that, how do they all piece together to change things?
So Viv, do you want to talk about this actually, because you've been involved in the MATNIA SIP work?
Yes, yeah,
implementation.
Yeah. So part of the work that I undertake is with NHS England, and we've been looking at the implementation of the Muse and U2. So Muse is an early warning system, which you write down all the observations of the woman that you're looking after, and then it will provide a risk score, and it will then it's got various stages of escalation. So a risk score of 0 is going to say, right, you know, she's okay, and just continue doing your routine observations unless you something happens and you feel that you actually need to step in before the next set of observations are due. And then as your scores rise up, then it will say, right, well, you need to repeat the observations. Oh no, you should get a clinical review, and it takes those steps going further. And what comes into that as well is, you know, this is a kind of multidisciplinary approach with that. And the U2 is for the newborns as well. And that's the same thing based on a risk assessment. And where Martha's Rule comes into it in culture is that everybody feels like you mentioned before, Hayley, it's been important for you to feel that your voice has been heard during a pregnancy. And that's what we want to offer to anybody, whether it's the woman herself, whether it's, you know, her partner, whether it's the birthing partner, you know, anybody, if a mum's in with her, you know, then anybody that is worried, or you can come and you can say, right, it was the student midwife who's been in with her and thinks something's changed and I don't know. You don't have to voice what it is, but you just say, I'm not happy. And then that will actually give itself a score. And then that can actually mean that somebody else will come and see the lady. So it's all about the culture that we listen to each other, we listen to the mother, everybody is involved in that care, and everybody has a say in that care and opening up that.
Yeah, really nice. And actually, it's the experience that I've had. My partner was quite nervous about asking questions at first because he thought, "Well, am I allowed to ask questions? Is it about me?" And I was like, "Of course you are." And I think after the first appointment, he was like, "Oh, I can have a voice too. I can ask questions," because obviously he's not experienced it and doesn't know what's going to happen, and he's concerned and scared as well. So, yeah, it's nice to see that it's not just the mum. Obviously, the mum's voice is incredibly, incredibly important, but family is also important too. So,
You're all going through the journey, Hayley. And when I
yeah,
first started in midwifery in the 70s, you know, the partner, well, he didn't normally come to hospital and he was certainly left at the labour ward doors. You know, there was no involvement
yeah,
of anybody in that care. The mother came through and you know, did the journey herself. And how
yeah,
frightening and how fantastic that we're offering what we are offering these days, you know, which
yeah.
is everybody's there, everybody's
Mm.
involved.
Yeah, my grandma's 86 or 88, can't remember, and she was quite a senior nurse, and obviously worked in the NHS for a whole career. And she, when I found out I was pregnant, she was talking to me about the changes and how she did it all herself, and she looked after women. There were no men, and we're strong, and we're built of strong stuff, and made me
Yeah.
laugh. Um, okay, no, that sounds it's really, really positive steps anyway, and I'm seeing it myself. And I think the achievement that you've made, even though there's still lots that you're working on and lots of programs, but you've made a huge achievement in Yorkshire and Humber. What, in very simple, like obviously there's probably loads you could say, but in very simple terms, what has it taken to get to where you are today?
I think it's taken, so to start with, I think it was regional acknowledgement. So at a managerial level, so the regional maternity team at the start of this were hugely supportive of setting up the project. And over time, the project has moved from the regional teams. It's now sits within the Improvement Academy, which oversees a lot of improvement work both within the region and nationally. And their support has been hugely important in terms of providing home for MIAC, and also people and time and resources to actually continue to do the work. And also, I think the buy-in more from the local maternity and neonatal systems. They can all see the benefit and have been very supportive of the work that we've been doing. And then the individual trust. And I think because this is a very much a kind of shop floor project, it all started actually, or my journey started as a new consultant coming in, and one of the, at the time, quite junior midwives coming up to me and very directly saying, I have absolutely no idea what I'm doing with looking after sick women. Can you please do something to help us to do this better? And it was really honest of her, and it was very direct. She's still very direct. She's a band 7 midwife now in Bradford. But actually, that kind of willingness to want to learn and to change the kind of knowledge and experience that the team had was really important, because I think without the staff really seeing the value of it and wanting to be part of the solution and to caring for women in a different way to improve outcomes, it wouldn't have got off the ground. And I think because the staff on the shop floor can really see how important this is, that's why we've had so many cases entered into the database. So every single one of those 7,000 cases has been manually data entered by a member of staff in those individual trusts. So that is hours and hours of people's time, which if they didn't want to do it or see the importance, just wouldn't have happened. So we're hugely grateful to everyone who's been involved in this. We're trying to look at how we can make that easier for them by automating the data input. But it is a huge achievement that we've got to this point. And I think there's a lot of people who have made that happen at all different levels in the NHS, and just hugely grateful to all of them.
And I think just to come on to the the end of what Debbie's saying, you know, that's been part of the culture. You know, it's been part of listening to everybody buying in this whole multidisciplinary aspect of it. Everybody wants to improve care.
It is really heartwarming to see how much passion is in this, well, industry as a whole, but specifically in the area that you're working on. And also, I'm excited about some of the future projects that you're working on. So you talked before about the improvement program around postpartum hemorrhage. So what does that look like, and what are you trying to achieve with that?
So in terms of the postpartum hemorrhage project, because that's the biggest group of women requiring MEAC, it seemed a sensible place to start in terms of really using that data that we've got to start to look to improve outcomes. There's some national work at the moment around improving outcomes for women, and part of that will focus on PPH. Which is postpartum hemorrhage. And so the good thing that we have in Yorkshire and Humber now is we're ahead of the game in the way, because we've got our baseline data already. So that already sits within the MEAC database, because we've been intending to look at postpartum hemorrhage or we thought that postpartum hemorrhage was something that we were going to be wanting to look at. So we put quite a lot of detailed information into there. So the great thing about that is that we've got really rich baseline data. That means once we implement the care bundle for looking after those women who've had a bleed after having their baby, we'll really be able to see whether that is helping to improve outcomes, because we've got that before and after data.
Yeah.
And then in terms of other projects that we're looking at, we've got a lot of data within the MEAC database around how unwell women are. So not just the numbers, but how severely unwell did they become? How long did they need the enhanced maternal care for? What was the impact on the babies? Where did the babies need to be cared for? Did they stay with mum? Did they need to go to neonatal unit? So we've got all of that data. There's various other big data sets nationally and regionally, which we are thinking of joining with, so that we can look at a broader impact of MEAC. But the other thing that we're thinking about is actually, can we start to think about context sensitive risks? So we know that we've got early warning scores, and they will help to predict which women are going to become unwell. But can we use the MEAC data to say, okay, if you are a woman who has come in at this time of day, you've needing enhanced maternal care, this was your early warning score when you came in, are there certain groups that we need to be especially worried about? And does it matter what time of day they come in? And does it matter who is present on delivery suites? So was it that there were a load of other patients on there who were also very sick? Were there gaps in staffing? What was the seniority of the people on delivery suite at the time? And what can we do to help staff to recognise that they're at risk of having a critical incident because of a woman becoming unwell? So there's a huge amount that we can start to use the data with, if we combine it with other bits of data, both within individual trusts and also more widely.
And I think to add to that as well, you know, we're also looking at what support is a woman given after she's actually experienced an episode where she has been unwell. And we're starting to work now with the women themselves, the users, to find out, you know, what was available, you know, what support was available. Did you access this support? If you didn't, why didn't you? And looking at a whole range of support for women afterwards.
And then I just wanted to speak about a slightly different topic, like the kind of the human in this. So Viv, I noticed you spoke really openly about burnout. And as you went through your career, questioning kind of whether the care that you were providing was safe and effective. And I thought it was a really brave thing to speak about. what was that moment like when you were sort of reflecting on some of those days and how things are changing now?
I think yeah, I don't feel it was brave to admit it, because I think it's something that we speak more openly about these days. But back in the late 90s, I decided to undertake further education, and so I was studying with my masters, and we had got into the cycle of reflection by this stage. Have a think about what you're doing, think about why you're doing it. We were becoming more research based as a profession, and I had to do a personal reflection. And I think one thing that had worried me, I was working full time as a community midwife, that was that I noticed in myself, I felt I was detaching sometimes. I didn't feel as I was feeling it's a very emotional journey that we take as health professionals with the pregnant lady and the family, and I think even more when you know the whole family is on community. And I felt that I was beginning to detach from some of the ladies' problems, not causing harm, to them at all, but was I giving my best, and then that I began to think, well, am I as effective? And am I doing it right? And and am I giving the care that they so richly deserve? And so writing about this was horrible. Reading about it, actually looking at the signs of burnout, and discovering that I had classic signs of burnout was so difficult. And I remember this, it was ridiculous. I got this assignment given back to me, 85% at master's level, everybody would be skipping all the way to the bank with that one, and would I think about publishing it? And I thought, I can't publish this, because people would know how I felt. So I got some help. I think your help's all about seeking support. It was talking, it was kind of setting some boundaries, and prioritizing myself, in a midst of being a mum, a wife, a midwife, studying and everything, and actually recognizing those symptoms that are there, the lack of self-motivation, the disconnection from what you're doing, you're feeling ineffective. And then in the midst of this, I was doing my master's, and so I thought, right, actually, can I do something else? Can I take some of the pressure off? So I decided to go into research, and I decided kind of to reinvent the wheel a bit at that stage. It took me about 3 years to step out of midwifery, out of community midwifery, because I'd done that for 20 years. I loved it, but actually I looked at myself and thought, right, well, what else can I do? So I had mentoring, and they said, well, actually, we think you might be quite good at project managing, so then, I went into research. I was offered a job. I started up the research team, and worked regionally and nationally, and internationally as well. It's been a fantastic career, and it's interesting how it's brought me back to Debbie and brought me back to working, with MIAC. So it just shows, that there are many professions that we can follow down, and sometimes actually we've given what we could do in that moment of time to that certain aspect of the profession. But there's actually lots more roads that you can take out there. And I would say to anybody, you are going to have to work through it yourselves. You are going to feel, horrible and unhappy, but it doesn't mean you have to leave. It means that you can actually work through it, get support, continue, but maybe down a different road.
Look at you now.
One day I will retire.
Not today, babe.
Yeah, not yet.
Okay, final couple of questions, really. So what would you say to other maternity leaders or hospital execs that are kind of thinking about investing in this kind of infrastructure?
Do you want me to take that one?
Come join us.
Yeah, I think I'd say the same as Viv. I think that getting the basics right, which, to be honest, a lot of MIAC is about the basics, getting the basics right in terms of equipping our staff with the competencies that means that they are able to recognise and look after sick women, and also really encouraging that multidisciplinary working, because at the end of the day, a midwife has loads of skills that are really important for looking after a woman who is having a baby and the baby when that baby is born. A critical care nurse has loads of skills in looking after really sick women in an intensive care environment. Anaesthetists, obstetricians, neonatologists, they all have specific skill sets. Now, there's overlap between all of them, but they're not all exactly the same. So there will never be a situation where one person can do everything. And it is absolutely a team sport, which means that if you work well together as a multidisciplinary team, you will get the best outcome. And then following on from that is really listening to women and their families to understand their point of view and to support them to have the best outcome as well in that given situation. And I think if you take those very simple ideas, you won't go far wrong in terms of setting up your system so that it delivers the best care.
And when it comes to data, come join us. Collect the data. You know, when you're working in trusts, there's lots of different specialities that are competing for, you know, funding and everything for different aspects with it. Collect the data, then you would have evidence behind you to, you know, say, right, actually, we need to do this training. You know, this is the level of care we're providing. We want to enhance that care. What can we do? And it will help you so much with the rest of the organisation as well.
Who do they get in touch with?
Us.
That's fine.
Yeah.
And just to sort of end, I wondered if both of you could share maybe a moment that you look back on and you think, yeah, this is why I'm doing what I'm doing. I feel incredibly proud right now. Let's put you under pressure.
Go on, you go first. I'll think.
Well, I would say that you know, my whole career has led towards giving me the expertise to be able to do what I'm doing now. And I was going to retire, and I in fact had retired for a few weeks, and then I met Debbie, who was inspirational. I hadn't heard of enhanced maternal care. You know, I came along, I spoke to her. My interview was, why is it required? And there was all the knowledge in the background, you know, about the embrace reports for me and everything. But Debbie and, you know, Yorkshire and Humber put everything together, and you know, put a pretty good load of evidence there to say, come join us. And the most humbling part has been that, you know, we started the data collection during COVID. What a time to do that. And everybody has been on board. Every single trust has been on board. You know, it's been a wonderful collaboration to be part of and to be part of a name of, you know, and that's including, you know, you know, case capture, it's Athera, net solving, everybody has worked together. And that's what I love. It's the team looking to work together to improve care for women.
So I still work clinically in labour ward and on intensive care, and looked after lots of women who've become unwell. And I think the things that stand out, each of those individual cases where I think that things have gone better than they could have done because of the work that we've done, is super rewarding. And then I think the other kind of times where it kind of makes me stop and think about it is when either in my own unit or in someone else's unit, I hear somebody describing the care that they've given as that's just how we do it around here, and knowing that that is the work that we have been doing for the last 10 years and that it has become embedded as normal practice on that occasion. And that's hugely rewarding, because actually it's not about us as individuals and telling people what to do. It's about what happens and how services get transformed, and it becomes business as usual to look after women in this way and get the best outcomes.
I think it's incredible work, and I really hope that more trusts get on board for you, and for women like me as well. So yeah, is there anything before we close that you feel, I wish I'd said that, I want the audience to hear this? No. Perfect. Okay, well, that is a wrap for this episode of Behind the Mask. So I just want to say thank you to you both for joining today. It's been a really inspirational conversation, and I'm really glad that you were able to share the remarkable story of MIAC and the 10 years of building the infrastructure that is hidden, that saves a lot of mothers and babies across Yorkshire and Humber. So if this conversation resonated you, make sure you subscribe and follow along. We've got plenty more episodes coming up with the people who are helping to shape clinical excellence, often in ways that you don't see every day like this. If you'd like to feature on the show, just let us know and we'll be in touch. Thanks again for watching, and we'll see you next time on Behind the Mask. Thank you.
Thank you.
Thank you.